Hello, friends, and welcome to episode 1217 of the Juicebox Podcast. Today, I'm going to be talking about the iLet insulin pump with the Chief Medical Officer of Beta Bionics, Dr. Stephen Russell. Dr. Russell and I will go over questions from the audience as well as his feelings about the iLet pump. Nothing you hear on the Juicebox Podcast should be considered advice, medical or otherwise. Always consult a physician before making any changes to your healthcare plan. When you place your first order for AG1 with my link, you'll get 5 free travel packs and a free year's supply of vitamin D. drinkag1.com/juicebox. If you or a loved one has type 1 diabetes and you are a U.S. resident, I'm asking you to take 10 minutes to fill out the survey at t1dexchange.org/juicebox. Completing that survey helps significantly with type 1 diabetes research. t1dexchange.org/juicebox. If you're looking for community around type 1 diabetes, check out the Juicebox Podcast private Facebook group, Juicebox Podcast, Type 1 Diabetes. And as a matter of fact, we have quite a few users using the iLet pump. So if you have questions, join the group. It's absolutely free. This show is sponsored today by the glucagon that my daughter carries, Gvoke HypoPen. Find out more at gvokeglucagon.com/juicebox. This episode of the Juicebox Podcast is sponsored by US Med, usmed.com/juicebox, or call 888-721-1514. US Med is where my daughter gets her diabetes supplies from, and you could too. Use the link or number to get your free benefit check and get started today with US Med. Today's episode is sponsored by Medtronic Diabetes, a company that's bringing people together to redefine what it means to live with diabetes. Later in this episode, I'll be speaking with Jalen. He was diagnosed with type 1 diabetes at 14. He's 29 now. And a little later, he'll tell you about his life with type 1. To hear more stories with Medtronic Champions, go to medtronicdiabetes.com/juicebox or search the hashtag Medtronic Champion on your favorite social media platform.
Hi, this is Stephen Russell. I am the Chief Medical Officer of Beta Bionics. I am also an Associate Professor of Medicine at Harvard Medical School, and I see patients at the Massachusetts General Diabetes Center part-time. But most of my time now is spent working at Beta Bionics. I have been working on the Bionic Pancreas project for about 16 years now. Been working with Ed Damiano and Faraz El-Khatib from the early days of the Bionic Pancreas project, and directed most of the clinical studies that were done, pre-pivotal and pivotal, and joined the company in the end of 2022 to help to get the product approved by the FDA and prepare for launch.
Wow. Okay. So you have a good, healthy, long relationship with it. So you're going to have all the answers, right? Some of them.
Well, I'll do my best.
What's your education background?
So I have an MD and a PhD in biological chemistry, and I trained at UT Southwestern for my MD and graduate degree. And then I came to Massachusetts General Hospital for my internal medicine residency and stayed at Mass General Hospital for an adult endocrinology fellowship.
Okay, so did you do most of your work in endocrinology or is it internal?
So endocrinology is a subspecialty of internal medicine. Okay. So you have to do internal medicine residency first.
Okay.
And then you can subspecialize. And I chose to subspecialize in endocrinology.
I always like to know what made you choose it.
Well, I think it's partly the kind of work. It's, diagnostic work, solving puzzles, but also long-term management, trying to figure out how to help people live their best life with diabetes is appealing to me. And from the research standpoint, I've always liked intellectually curious. I like the fact that in endocrinology, there's control loops that are sort of intellectually satisfying. Mm-hmm. And so that was appealing for that reason, I think. And I knew I wanted to do some research. And there's just this great history of research that comes out of endocrine. I think something about hormones, they were accessible to work on early on. If you identified a hormone, not only did you have the hormone, but you had a drug. Almost all of those hormones were also immediately usable as drugs. Didn't have to go find a small molecule. So when insulin was discovered as the key element to control glucose, all you had to do was purify the insulin, not a trivial matter, but you had to purify it, figure out how to use it. You didn't have to then go and find some other small molecule drug that could act on the insulin receptor. It's perhaps a shorter path from figuring out how the mechanism works to being able to do something with that information to help a patient.
Okay. So then is it fair to say that those things that light you up are maybe one of the reasons why somebody came and found you for this 16 years ago?
Well, we sort of found each other. So
Okay.
Ed had started to work on the bionic pancreas algorithms because, as is well known now, he had a son who developed diabetes at 11 months of age. He was an applied mathematician doing fluid mechanics, but thought maybe he could use his applied mathematical skills to improve management of diabetes. And he was to the point of doing studies in pigs that he made diabetic with for us, and they were doing these studies with an earlier version of the algorithm. And he came to the Joslin Diabetes Center to report on that work. And I was there doing a postdoc, trying to understand how insulin signaling affects longevity and aging.
Mm-hmm.
But I also had a side project looking at accuracy of CGM in people in the hospital and critically ill. So we reported these data using both insulin and glucagon. And I really liked that approach. It was kind of contrarian at that point because people said you couldn't use glucagon as part of a control strategy. And sometimes when people say something can't be done, it's true. But in many times, they just haven't opened their mind and really investigated it. So I was intrigued by that possibility. So I approached him and said, hey, you're doing these animal studies. Could we work together to do studies in humans? And he was enthusiastic about that prospect. And from that point onwards, we started writing grants and planning studies, and we've been working together ever since.
It's interesting. It's interesting how you can ask a question and somebody will say, no, absolutely not. Or, maybe. And, like that, the no, absolutely not people, like, are they so tied to what they know that they can't see the rest of it? Is it just comfortable for them? It must make all of these things difficult in an academic setting, right? Because so many people tie their ideas to who they are. You know what I mean?
Absolutely. I mean, if somebody has been working on insulin-only automated insulin delivery or insulin-only automated glucose control for a long time, and then you come in and proposing using a second hormone, I think that can be kind of threatening.
Yeah.
And it can feel like, wait a second, you're encroaching in my territory. We're going to do this way.
Right.
At one point, I had somebody not to be named come up to me and say that nobody should be working on bihormonal glucose control until there was an insulin-only system on the market. And I thought, that doesn't make a lot of sense to me.
Someone told me one time that I couldn't make a podcast and talk about how we manage my daughter's blood sugars. If you take insulin or sulfonylureas, you are at risk for your blood sugar going too low. You need a safety net when it matters most. Be ready with Gvoke HypoPen. My daughter carries Gvoke HypoPen everywhere she goes because it's a ready-to-use rescue pen for treating very low blood sugar in people with diabetes ages 2 and above that I trust. Low blood sugar emergencies can happen unexpectedly, and they demand quick action. Luckily, Gvoke HypoPen can be administered in 2 simple steps, even by yourself in certain situations. Show those around you where you store Gvoke HypoPen and how to use it. They need to know how to use Gvoke HypoPen before an emergency situation happens. Learn more about why Gvoke HypoPen is in Arden's Diabetes Toolkit at gvokeglucagon.com/juicebox. Gvoke shouldn't be used if you have a tumor in the gland on the top of your kidneys called a pheochromocytoma, or if you have a tumor in your pancreas called an insulinoma. Visit GvokeGlucagon.com/risk for safety information. And now 17 million downloads later, it helps people in 48 different countries. So if I would have listened to that person, none of this would have happened. So here's to people who don't listen. That's great.
Yep.
So now we've got, we'll fast forward all this way. You go through this entire process. You get a device. It gets its way through the FDA. It's available on the market now. I always, when I'm thinking about iLet, I want to know if I'm clearly understanding what it is. And I'll just tell you that from my perspective, it seems like a fantastic device. If someone has an elevated A1C and struggles and can't figure things out about how to dose or count carbs or anything, like, to me, this seems genius. I mean, if you're a person walking around with a 10, 11, 12, 13 A1C, and you tell me I can put the iLet pump on and announce meals like, I mean, what are the announcements? It's snack. How does it go?
Breakfast, lunch, or dinner, and usual for me, more or less.
Okay. So I make those two announcements and I get an A1C where?
Well, on average, 7. About half of the people in our pivotal trial wound up with A1Cs below 7 and about half above 7. And most of those were below 7.5.
Okay. That's astonishing. So that's my point. For every person who listens to this podcast and firmly understands pre-bolusing their meals and adding insulin for fat and protein and all the other things that you need to understand to keep stability. I mean, I don't know the number, but there's got to be 100 people who don't understand it or never going to even intersect the information. And if they did, they might not get it. So am I thinking about that right? Or am I undercutting iLet by thinking about it that way?
I think you are undercutting a little bit. I think you're right. It's definitely great for people like that. And we wanted it to work for people like that. There's a lot of people out there who aren't being served by the current or previously available diabetes technologies before iLet. And we know that that's the case because only 20% of people in the US with type 1 diabetes at expert centers have an A1C less than 7%.
Mm-hmm.
So that's a pretty sobering statistic. The average A1C of people with type 1 in the US is about 8.2%. So that tells you that the current methods are not sufficient. And that hasn't changed, by the way, very much as we've gotten CGM and AID. I think a lot of the new technologies that we've gotten have allowed people who already had pretty good glucose control to get even better glucose control. But what they haven't really done is allowed people who weren't getting good glucose control to get good glucose control. And I think that's where the iLet is really different. One of the ways. The sense that I think you may be underselling it is even people who have good glucose control are often spending more time managing their diabetes than they would ideally like to do. There's an enormous mental overhead associated with managing diabetes. It just takes a tremendous amount of thought and effort and time and consideration to achieve those kinds of results even for the people who are achieving good results. And I think that there's a real opportunity for those people to continue to get good results, but with less effort on their part. Mm-hmm. What we found in the pivotal trial is that for people who already had an A1C less than 7% at baseline in the trial, their average A1C did not change on the iLet. So if they had an A1C below 7% on average, they still had an A1C below 7%. It was about 6.5% for people on the iLet, for people who already had an A1C below 7.
Okay.
And they did that with a lot less effort. And you don't really capture that in the numbers, but we did do patient-reported outcomes where we ask people using these standard sorts of questionnaires, essentially, how are you feeling? And what we found is that they had less diabetes-related distress, less fear of hypoglycemia, better quality of life. And those are things that don't show up in those A1Cs or those average glucose numbers, but are real and matter.
And so are you saying that people who had a better understanding to begin with, generally speaking, didn't see a rise in A1C when they moved to iLet?
That's true.
Yeah.
What we did see is that as I said, on average, their A1C didn't change on the iLet if they started off already meeting goals for therapy, if they already had an A1C less than 7%. And if you break it down further and look at that group, some of them had no change in their A1C from baseline. Some actually saw further decreases in their A1C on the iLet. Mm-hmm. Some actually saw increases in their A1C, although by and large, they still stayed below 7. But what was interesting about those people who saw rises in their A1C, they generally had significant reductions in their time less than 54. So they were seeing an increase in their A1C because they were having a lot fewer lows.
People who were coming to their A1C sort of not honestly, right? Like it was being offset. Their standard deviation was being offset by low blood sugars.
That's right.
Okay.
And on average, the iLet didn't change the amount of time less than 70 or less than 54. There was no difference in the control group and the iLet group in time less than 54. The median was 0.3% of the time less than 54, and that was true in both groups. Mm-hmm. But that does conceal a little bit. That conceals interesting things. So for people who had very high levels of hypoglycemia at baseline, the iLet decreased them quite a bit. For people who had none at baseline, it tended to increase it a little bit from, say, 0 to 0.2% of the time. And that might be the cost of, somebody having an A1C of 10 or 11 or 12 with zero hypoglycemia. You bring them down to an A1C of 7 or 7.5, they're going to have a little bit, but still acceptable amounts. And then people who had hypoglycemia below 1% at baseline, typically no change.
Mm-hmm. Okay. So I have a ton of questions here. And if Certainly. You don't mind, I don't mean rapid fire like we're going to be exhausted and sweating when it's over, but I'd like to maybe lose the conversational nature of this a little bit and go to more of a question answer if you don't mind.
Of course.
Okay, that's excellent. Thank you. Let's start with kind of the basic stuff. Let's just start with dosing. Like you just said, breakfast, lunch, or dinner. So you pull up your pump and say, hey, it's breakfast and I am having an average meal for myself. Do I pre-bolus that?
We suggest that you announce the meal at the time you're starting to eat it.
So that's a no then to the pre-bolus.
Right. If you are, some people really like to do that and find that, they might get, some people say that they get better glycemic control, less of a postprandial excursion. If you're going to do that, though, you need to do it consistently because it will affect how the iLet learns how much insulin you need for that meal.
Okay. Let me jump to that word then. Learn. What does learn mean in regards to iLet? How does it learn? What does it do with that information? How does it change the future?
Sure. It depends on which part of the insulin dosing you mean. So there's a basal algorithm that learns, there's a correction algorithm that learns, and then there is the meal dosing algorithm that learns. And it is unique in that all of those do truly adapt and learn the individual's insulin needs. Most of the other AID systems don't actually adapt or learn anything. The one exception I would say would be Omnipod 5 because it does actually determine the basal dose. It updates it every time you change a pod based on the average basal for the previous pod. Mm-hmm. But all of the other systems and all the other aspects of Omnipod 5 are just reacting to the circumstance at hand.
Right.
It's not changing how it doses in the future, but with the iLet, it truly is learning and adapting. So you ask about the meal doses. What we do is for each of those meal types, breakfast, lunch, and dinner, which adapt independently of each other. Mm-hmm. The iLet initially, the first time you announce a meal, it gives just a very small weight-based dose, which is 0.05 units per kilo. So if you're an 80-kilo person, it would be roughly 4 units, which for most people isn't enough. Then what it does is the corrections algorithm automatically provides additional insulin to correct the blood glucose back down to the target. And it keeps track of how much insulin it needs to do that over the next 4 hours. Then the next time they announce another, say, usual for me breakfast, it looks back at that previous meal and say, oh, I gave 4 at the beginning, but then I had to give another 4 correction. So it looks like a usual for me breakfast needs 8 units. And then the iLet gives 75% of that. Mm-hmm. So 6 units. Again, that's because we want usual for me to be most of the meals. We want it to be a range so that people aren't counting carbs. They're just qualitatively estimating. And then the next meal keeps track of additional correction insulin. Maybe this time it uses a total of 9 units. So the next time you announce a usual for me breakfast, it averages those 2 previous meals. And it keeps doing this up to 7 meals. And so it's constantly looking at the average of the insulin dose it thinks you needed for the last 7 meals. Once a data is 8 days old, it's forgotten, and you've brought a new day in. So we're always looking at the average amount of insulin needed for a meal announced that way over the last 7 days.
Okay. That's
and then we give 75% of that.
What happens if in the middle of that week, I throw breakfast sausages or bacon in with my meal that I haven't had before, and suddenly my digestion slows down? It'll address that as a higher blood sugar when you get the fat rise? This episode is sponsored by Medtronic Diabetes. MedtronicDiabetes.com/juicebox. And now we're going to hear from Medtronic champion, Jalen.
I was going straight into high school, so it was a summer heading into high school.
Was that particularly difficult?
Unimaginable. I missed my entire summer. So I was going to a brand new school. I was around a bunch of new people that I had not been going to school with. So it was hard trying to balance that while also explaining to people what type 1 diabetes was. My hometown did not have an endocrinologist. So I was traveling over an hour to the nearest endocrinologist for children. So, outside of that, I didn't have any type of support in my hometown.
Did you try to explain to people, or did you find it easier just to stay private?
I just held back. I didn't really like talking about it. It felt like it was just a repeating record where I was saying things and people weren't understanding it. And I also was still in the process of learning it. So I just kept it to myself, didn't really talk about it.
Did you eventually find people in real life that you could confide in?
I never really got the experience until after getting to college. And then once I graduated college, it's all I see. You can easily search Medtronic Champions. You see people that pop up and you're like, wow, look at all this content. And I think that's something that motivates me. Started embracing more, how I live with type 1 diabetes.
MedtronicDiabetes.com/juicebox to hear more stories from the Medtronic Champion community. I used to hate ordering my daughter's diabetes supplies. I never had a good experience, and it was frustrating. But it hasn't been that way for a while, actually for about 3 years now, because that's how long we've been using US Med. usmed.com/juicebox or call 888-721-1514. US Med is the #1 distributor for Freestyle Libre systems nationwide. They are the #1 specialty distributor for Omnipod DASH, the #1 fastest growing tandem distributor nationwide, the #1 rated distributor in Dexcom customer satisfaction surveys. They have served over 1 million people with diabetes since 1996, and they always provide 90 days worth of supplies and fast and free shipping. US Med carries everything from insulin pumps and diabetes testing supplies to the latest CGMs like the Libre 3 and Dexcom G7. They accept Medicare nationwide and over 800 private insurers. Find out why US Med has an A+ rating with the Better Business Bureau at usmed.com/juicebox, or just call them at 888-721-1514. Get started right now, and you'll be getting your supplies the same way we do.
Well, there's going to be really 2 effects of that, right? One is that it may slow down the absorption of the carbs, but it may also make you have to get more insulin ultimately because the fat is interfering with the action of insulin. That's part of the reason that we only give that 75%, because we don't want to overdose right up front if somebody eats on the lower side or, for instance, eats something that's going to slow down their absorption. So we tell them not to consider the amount of protein, not to consider the amount of fat. That's part of why we're conservative with that initial dosing, knowing that our corrections algorithm can come in and fill in any gaps. Mm-hmm. So there's an element of adaptation. It's learning how much it thinks you need, but then we're only giving 3/4 of that. And then there's an element of being reactive to how this meal might be different from previous meals.
Right.
Because the correction algorithm, it doesn't, give 75% and then give the other 25%. It gives 75% and then just sees whether more is needed. Mm-hmm. maybe none will be needed, or maybe it'll be needed later in that 4-hour period than earlier because they had more protein.
If I flip that on its head then, and I eat that fattier meal 2-3 days in a row, and then the fourth day I have the same amount of carbs, but just nothing that's going to slow down digestion, am I going to see a low blood sugar there?
Well, if you have nothing that's going to slow down the absorption, the glucose may be absorbed faster. You may get a sharper spike, actually. And so the correction algorithm may jump in sooner to give more correction insulin. But then, because there's no fat or protein slowing it down, it may not need to give any more after that initial dosing.
But in that situation, if the carbs are the same 5 days in a row, the first 4 are fat laden, and so it's correcting. On the fifth day, does it not think breakfast is going to need more, and then suddenly it doesn't? That's where I'm asking, like almost like with
right,
yeah.
But that's part of why we only give 75%.
That's what helps that. Okay,
yeah, okay. Exactly.
Okay.
Yep.
It's interesting. Now, what happens? I mean, do you see? I guess the question should be: do you see in testing or with real life use high blood sugars that it just can't affect? Like, what happens when a person who's used to taking care of their blood sugar is looking and saying, God, I have been 250 for 3 hours. I want a bolus here. Like, what are they supposed to do then?
Right. I think that does sometimes happen early on before the meal doses have had a chance to adapt. So it's almost by design that you probably, if you're somebody who needs more insulin than that sort of low initial estimate, almost by design, you're going to see hyperglycemia after that first meal. And the iLet needs to see that hyperglycemia to give correction insulin to know that you're going to need more insulin next time.
Okay.
And so if you are patient and wait, and assuming your infusion set is working and it hasn't failed or anything, the iLet will bring your blood glucose back down into range. And then the next time you announce a usual for me breakfast, it will increase the amount of insulin that it gives you for that meal. So you do have to be a little patient over that first day or 2 or 3 or 4 days in some cases for the iLet to learn how much insulin you need and to adapt up. And if you short circuit that process by, say, I can't stand this, my blood glucose is 250, I'm going to have to do something. Let's say you give insulin that the iLet doesn't know about. You give an injection and the iLet doesn't know that you gave that injection. Now the iLet doesn't think you need more insulin. So the next time you announce a meal in the same way, it's not going to give more insulin because as far as it's concerned, you didn't need more insulin. You came down on your own. Or if you announce a fake meal, do another meal announcements, even though you're not eating more. Well, we have certain rules about our adaptation. If you announce another meal in that period, that will cancel the adaptation because we can't tell which insulin we're going to give is ascribed to that first announcement or the second announcement.
Sure.
And so we just decide, okay, we're not going to learn from that announcement. We're conservative about which meals we use for learning, and that's fine as you're using the device over a long period of time. You don't have to adapt on every single meal. But if you consistently are using extra insulin, either by giving insulin the iLet doesn't know about or doing additional announcements, you will completely block its ability to learn that it needs more insulin the next time.
Mm-hmm. How long do I need to be on the device before I don't expect it to struggle?
Well, it varies a little bit from person to person. It depends on how high your total daily insulin dose is.
Okay.
But I would say that if you follow the recommendations for allowing the iLet to learn you, most people have gotten to a pretty good place in terms of their meal announcements within 5 to 7 days.
Okay.
Now, what we found in the pivotal trial was that on average, people got to their new time and range within 48 hours. But that doesn't mean that the meal doses had adapted that fast. What was happening is that the iLet was relying more on correction insulin, the correction algorithm, and they were getting under pretty good glucose control on average within that 48-hour period. But over time, there was a shift as more insulin was coming in from the meal algorithm and less insulin was being delivered by the corrections algorithm.
Okay. So here's my next question then. Exercise. Like I have a message here, a question. This person says they're a camp director at a T1 camp. He says, we have many families that are on iLet they're debating on sending their kids to camp due to concerns that there's no way to reduce basal for demands of camp. These people are citing to him that they are having issues around activity with no way of announcing activity or reducing basal. So what do you think about that?
My recommendation to kids going to camp is to think about how much their activity is actually going to change at camp. Because some kids are much more active at camp than they are at home, and others are not. So if they're not going to be more active, it's probably not going to be a different issue than whatever they've been addressing at home. If they are dramatically increasing their activity, then one of the things they could potentially do is raise the glucose target. That's a lever that we haven't really talked about to date, or at this point in the discussion, but there is the possibility of changing the glucose target. I would say that, exercise is a whole conversation.
Yeah.
And right now we don't have an exercise mode for the iLet. What we recommend is that people, for the most part, keep the iLet on. And most kinds of exercise actually don't cause the blood glucose to drop. Weightlifting, high intensity interval training, and so forth typically don't cause a drop in blood glucose. And so it makes sense to leave the iLet on and running. For exercises that do cause the blood glucose consistently to drop, the recommendation is to do one of two things. Either leave it on, it'll see your blood glucose drop and it'll suspend insulin. And you may still need to take some carbs to cover that period until the insulin levels, the insulin on board decreases. And that takes some time because it takes, on average, 5 or 6 hours for insulin to really clear. And so you should definitely have some carbs available and then take whatever amount of carbs is needed to keep you from going low, although try not to over-treat the low so that you're not provoking the iLet to give more insulin. Or you can just disconnect from the iLet. And that way the insulin levels will obviously be much lower. And if you disconnect from the iLet, then you have the option to take some carbs to raise your blood glucose.
Okay.
Going into the exercise. Just like any other AID system, it's really important not to pre-carb load for exercise without disconnecting from the iLet, because then what you'll do is you'll cause your blood glucose to go up. The iLet will see that and respond to it with additional insulin dosing. And so then you're going into exercise with even more insulin on board. We are aware that there is, I think, a need for an exercise mode for the iLet, and we have designed one, and we're working on the strategy for getting it out there. We have to talk to the FDA about, what the appropriate way is to get that update out. And once we have clearance for that, it'll come out just like any of our other over-the-air updates.
Okay. Is that you hope for this year, or you can't even say inside of a calendar year?
I think that I better not handicap our chances of getting it out in a particular time frame. I certainly hope for it this year.
Okay. You're working on it now. You hope for it this year. Okay. Well, that maybe does answer that question. Hey, you talked about targets. What do you mean that you haven't been telling people that there's targets? What is that?
Well, we hadn't talked about it in this conversation so far.
What are the targets that I can set with iLet?
So there are 3 levels of target. There's the usual target, the lower, and the higher target. We intentionally don't talk about what glucose level those are right up front, because we're trying to simplify it to allow people to manage their diabetes without thinking about numbers. But everyone wants to know what they are. And they are 120 is the target for usual, 110 is lower, and 130 is higher. I just want to make the point that they aren't directly comparable to targets with other systems because the algorithms work differently. So Ed likes to joke that if somebody asks what the targets is, he's like, well, what is the gear ratio in your car? What matters is not actually what the target is, but what kind of average glucose you can achieve with it. And what we found in the pivotal trial was that about 60% of the time was spent with the usual target, 20% with the lower, 20% with the higher. And with that mix of targets, we had an average glucose of about 155 in adults. So, right at an average A1C of 7%. But of course, the target for a particular person is what's appropriate for that person.
Right.
And I should also point out that you can have 2 different targets a day. So you can have one target during the daytime and one target at night, and you can choose the timing of the start of that daytime target and shifting back to the nighttime target. They can be at any time.
Mm-hmm.
So that's something that we think people shouldn't just do on their own. They should talk to their healthcare provider about, but it's not uncommon to have 2 different targets, one during the day and one at night.
Can they be automated?
Yeah, they are. So
Okay.
Once you set the pattern, it's just a recurring pattern.
It just happens. Okay.
So, probably the most common target is just to be at the usual target the whole time.
Mm-hmm.
But probably the most common after that is to have a target that's one step lower during the daytime when people are eating, and a step higher than that at nighttime when they're not. And that means the iLet can be a little bit more aggressive at dosing any postprandial, any after eating rise in the blood glucose.
Okay.
And it just tends to make it more efficient at managing any hyperglycemia during the day for some people.
Mm-hmm. My next question is from a woman who says that her husband has a coworker friend who's using iLet, but the guy's a snacker and the pump doesn't seem to be handling that well. So what should I do if I'm the kind of person who walks through the room and grabs 7 carbs of something and throws it in my mouth?
What we recommend is that people announce carbs that they're eating, snacks that they're eating, if they have as many carbs as a meal. So the usual for me meal is 1. A less meal is half of that, and a more is 1.5 times that. So those are sort of the levels of what we call a usual for me, a more and less meal.
Mm-hmm.
So if a snack has as many carbs as a less meal, so it has as many carbs as half of your normal breakfast or half of your normal lunch, or anywhere down to a quarter. So that range is like a quarter to 3/4. That's a less meal. If it's anywhere in that range, they should go ahead and announce it. We say if it's less than a quarter of a usual meal, they shouldn't announce it, and they should just let the correction algorithm manage it. But if it's, in this case, if they're finding that they're having hyperglycemia after not announcing those snacks, my guess is that they have significant carbs in them, and they probably should be announcing them as meals.
So you're thinking already about the activity addition. Do you think about like a grazing mode, or like, you know what I mean? Listen, you've been an endo for a long time, right? So Thanksgiving comes, I tell people all the time, like, put your basal up 20%. Like, you know what I mean? Like, you're going to be eating throughout the day. Like, let's lay a heavier, a blanket of insulin over this situation. Like, is there thoughts about, like, I guess my real question should be, as you're seeing it in people's hands, are you thinking like, oh, this would be good to add? Like, are you having those thoughts?
We actually have designed a snack announcement that will be even less insulin than a less meal.
Mm-hmm.
It'll be kind of a different category. I would say that for most snacks, if they're causing a significant rise in blood glucose,
it's a meal.
They probably should have been announced as a meal.
Right. But I'm talking about like the real, like, like, I don't know, a candy bowl and you grab 7 gummy bears and it's 8 carbs or 9 carbs or something like that. And like, you have no ability to, maybe the biggest like sticking point right now. And I'm certainly not leaning into it. I am not a person who says I don't want to change. Right. So I don't get upset when Facebook changes the way it looks. If a car company puts out a card, it's not quite done yet. I'm like, oh, if this is what they need to do to get to it, like, I'm okay with it. Like, so I'm flexible about that stuff and about diabetes as well. So my question, I guess, is how do people who are just so accustomed to doing something one way, do you think if they just tried it, eventually they'd be like, all right, I'm good with this? Or do you think that there's going to be a happy medium in there? So you're looking for a snack button, you're thinking about exercise. I mean, I love the idea of iLet. Like, it's a romantic idea about taking good care of yourself with less input. Mm-hmm. But what does that mean, I guess? Like, I'm going on a little bit, but if you told me my daughter's blood sugar was going to be 155, I'd say, oh God, what did we mess up? Right. So like, I'd be looking at like, is the basal wrong? Do we have the insulin to carb ratio wrong? Like, there's part of me that feels like we're having this initial conversation with Beta Bionics, who is now looking at how to go to a bihormonal pump. And I'm thinking like, I'm going to look back on this one day and just see this as the infancy of the pump. Is that maybe how I should be thinking about that?
Well, let me say that I think we really see tremendous value in bihormonal. And the reason is I like to think about it in terms of a population health reason. Mm-hmm. With the iLet, we can get about 50% of people to have an A1C less than 7%, most of the remainder to have an A1C less than 7.5. With the bihormonal, we expect to be able to get 90% of people to have an A1C less than 7 and 100% to have an A1C less than 7.5. That's what our pre-pivotal data says. So it's lowering the average glucose, if you will, by about another 15 mg per deciliter, or about another 0.5% of A1C. Why do I keep talking about 7 and 7.5? Obviously, 7 is the recommended A1C target that ADA has come out with, and that's based on the Diabetes Control and Complication Trial. It's worth pointing out that the Diabetes Control and Complication Trial started with people who had an average A1C of 9. And what they found is that if they got their control group that had, and I want to point this out, an average A1C of 7%, not everyone got lower than that. The intensive control group had an average A1C of 7%. They found that that was sufficient to cut the progression of complications or the development of new complications to the background level. Mm-hmm. So if you look at that hockey-shaped curve of complications versus A1C, below 7, there is no signal for further progression of complications. Since that time, there's been some data like registry studies from the Scandinavian countries that look at people who have been in there, everyone who gets diabetes is immediately tracked. It's like a registry studies the whole country. When they go back and look at that, they find that people who had an A1C below 7.5 from shortly after the time they were diagnosed throughout their entire lives never get complications of diabetes. And one more piece of information is people who have what's called glucokinase MODY. It's a particular single gene mutation that means that people have a average glucose from birth in the 160 to 170 range. They're born, their pancreas works, it just works for a higher set point. Mm-hmm. So there's several thousand of these people in the world. They've been carefully studied, followed throughout their lifespans. They don't get any complications of diabetes. So I think that probably if we were able to get everyone below an A1C of 7.5, diabetes complications wouldn't be a thing.
See, you bring up something that I never know how. I've been doing this a long time. And one of the questions that people ask me that I just don't know how to answer is, what is the benefit of being lower? And I don't know. I always say I have no idea. Like, I don't know. And it always comes down to, if you can, without it being too much trouble, I'd err on the side of doing it. I can't tell you. And those are interesting studies for certain. I think the problem ends up being, and this is obviously more philosophical than anything else, is that if it happens for a person, they live their whole life with a 7, for example, and then they have a problem, you can't go backwards and try again. Like, right. So there's that's the rub. And I also feel like if we were alone in a bar and I asked you if you were working on the algorithm having a lower target, you would be like, oh yeah, of course, Scott, we're on that. Don't worry. I'm just super interested in where this is all going. I love the form factor. I love how it wants to work. And I appreciate you sharing that information, because that's the closest I've ever come to an answer to that question. Like, what's the benefit of lower?
I would argue that there isn't evidence that there's a benefit for lower. Mm-hmm. So what do I tell people? I tell people that if you can achieve a lower A1C without hypoglycemia, then
great.
And you want to, then great, then fine.
Right.
But if there's a significant trade-off in terms of increasing hypoglycemia, it's not worth it.
No, I don't think so either.
And I would never target below, say, 6.5. I mean, there's, you just can't make an argument, an evidence-based argument for shooting for an A1C lower than that, in my mind.
Mm-hmm. Well, you're also not trying to sell a pump to somebody who's walking around with a 5.5 A1C to begin with. By the way, none of these algorithms, without some real, intervention, tinkering, deeper understanding, you're not getting there unless you really know that. Hey, that makes me wonder, how does the algorithm work for people who are very low carb?
It works great. I mean, that's an easy case.
Okay.
Those people tend to do well no matter what they do. Mm-hmm. So the algorithm works really well in that context.
Okay.
I kind of want to go back to that issue of, what's the advantage of going lower? And, as I said, I think that there isn't much evidence that there is an advantage in going lower. And if we go to the sitting in a bar scenario, the reason that I give for wanting to use the bihormonal system is that we can just get more people, in this case, everyone, to have that A1C that I think will pretty much eliminate complications. It's not about taking somebody who already has an A1C of 6.5 and bringing them down to 6. I do think that for individual people, because we can be a little bit more aggressive with the algorithm, it probably will give them the capability of lowering their A1C by another 0.5%. Whether they should is a separate issue.
Mm-hmm.
I would, at that point, if somebody has an A1C of 6.5, the way I would use glucagon is not to further lower their A1C, but to further lower their hypoglycemia.
Okay,
that's where the benefit comes from my perspective, and also it has the additional advantage of meaning that you don't have to take oral carbohydrates.
That's
with
right,
all
yeah.
these insulin-only systems, they're all pretty good at suspending insulin if it looks like the person's going to go low,
Mm-hmm.
but they all occasionally fail in that you still need to take carbs to treat a low. And, it's frustrating to people to be, doing exercise because they're trying to, trim down or something, and then they wind up having to take a bunch of carbs to treat a low that happens when they exercise. So the glucagon has an advantage from that standpoint. And it also just the spontaneity standpoint, not having to take carbs, just seeing your blood glucose going low and then just going right back up without you doing anything.
Yeah.
That certainly increases peace of mind. And, whereas with the insulin-only system, we found that we were able to lower that A1C by 0.5% on average, more for people who are higher. Obviously, we didn't lower it for people who already had A1Cs below 7. And we didn't increase hypoglycemia.
Mm-hmm.
But with the bihormonal system, we're able to lower it even further and actually also reduce hypoglycemia.
You're testing it now? Or
We are not testing it again yet. We just recently announced an agreement with Xeris Pharmaceuticals to test a new formulation of stable glucagon.
Mm-hmm.
And we're moving forward with that with all haste, because we really do think that bihormonal system is going to provide terrific advantages.
People who are listening right now, if you go back a week in the podcast, you'll see an episode with Xeris and iLet talking about that agreement that Dr. Russell just I've done an interview about that yet. That's going to go up right before yours does. I'm excited by it. Like, I have to tell you, my daughter's 20, right? For the most part, my daughter's away at college right now using IAPS, and she's got an A1C like 6.1, I think, and that's at college. Like, and not just at college like you're thinking of it. My daughter's not like a crazy party person. She's working incredibly hard, like 7 days a week, doesn't take off, long quarters that go into 6-month times when she's at school. And that she's managing that is insane. Absolutely fantastic. But we also do a really good job of her not having lows. Having said that, I've seen really emergent lows. And I watched her have a seizure when she was 2 years old. She had one when she was a high school senior. It was both times variables that were not common everyday stuff. I just think in my heart, if her pump would have noticed that and given her some glucagon, it might have been maybe the greatest thing that I'd ever seen in my life. Like, seriously, I don't know how people who are using insulin are not ultra aware of this constantly. To take that brainworm out of the back of my head would be amazing. You know what I mean? So I'm with you on that. This is probably an unfair question, but have you ever talked about, would you license this to other pump companies if they were interested? Or are you guys going to keep
the glucagon?
Your algorithm and everything? Like, at some point, I keep thinking at some point, one of these systems is going to show and everyone's going to say, well, yeah, that's how we should be doing it. And then what are we doing? Then we're in a retail game? Like, that's ridiculous, right? Like, at what point do we just say, because listen, I have my questions here for you. 50 people. This is nice. Will it ever be tubeless? So, like, you know what I mean? There are people who they don't care if it comes with a free pack of bubble gum, you know what I mean, and a bus pass. If it's not tubeless, they don't want to hear about it. Like, that was my wonderment. Like, you know what I mean? Like, I wonder if we'll really get into that interoperability that we all kind of got teased about with Tidepool. It doesn't seem like it's ever going to happen, I guess is what I'm saying. Yeah. We're
certainly aware that people are interested in the tubeless form factor.
Mm-hmm.
That's all I'm going to say about that right now, but
okay.
we are certainly aware of that. And we realize that that's really important for some folks. So,
all right, I take your point. Don't worry, I can read between the lines. I'm good.
As far as licensing the algorithm, I mean, Ed would be a better person to talk to about this. But we definitely were interested in making the algorithm available to other pump companies, and there were no takers. That's why Beta Bionics got started. Mm-hmm. The idea of having a system that's this automated was something that I think was scary to other pump manufacturers. And they preferred a system that still left more of the responsibility in the hands of the user.
I see.
So that if something went wrong, they could say, well, we're not responsible.
Omnipod's gotten away from that. They're basically telling you now, we don't even want you to understand how it's working. You know what I mean? Like, it's going to do what it's going to do and let it do it. And I mean, you're saying that too. You were saying, like, let the thing work, right? Like, don't.
Well, I think that it's different. I would argue, because we're very clear. We have a lot of information about how our algorithm works, and I think that's a little different than Omnipod.
Mm-hmm.
But Omnipod also still requires the user to do a lot. What I've learned clinically with the Omnipod is that if you want to get good glucose control with that system, you need to make sure that you fully dose your meal, your meal carbs.
Sure.
Because it's a fairly conservative algorithm in terms of giving corrections and adjusting basal and so forth. So you can get good glucose control with it, but you need to be pretty aggressive about giving the full amount of insulin for carbs and also giving manual correction boluses to get the best glycemic control. So it's still quite dependent on the expertise of the user in being able to count carbs accurately,
right,
and to choose the appropriate times to give corrections, and
mm-hmm.
To give the corrections that are needed and not give the rage boluses. So it still is quite dependent on the user, whereas the iLet is not. With the iLet, it's really more about not doing certain things that can confuse the iLet and sort of teach it the wrong things.
Right.
It's often about doing less with the iLet, not more. And in that sense, it's really unique. Every other diabetes control system, the more you interact with it, the more you pitch in, the better glycemic control you're going to get. And the iLet is unique in that that's not the case.
What's an average excursion I expect with an iLet? Like, what number am I going to see a spike go to, for example?
Well, if you have a meal and you do announce that meal and your meal doses have adapted, it might be quite small, might be 150, but it might also get to 200 or transiently above 200. It just depends on where you are in that range of what your usual for me meal is, for instance. How much of the insulin actually came up front and how much is coming as correction bolus.
I see. I mean, it's all like relative. Like when I tell people my daughter's A1C, I think they imagine like an 83 blood sugar that goes on for weeks and months, but she has spikes at meals just like everybody else.
And so do I, by the way.
Yeah.
I don't have diabetes,
yes,
but I wear CGM,
mm-hmm.
and my blood glucose goes above 200 sometimes.
No kidding.
Absolutely.
Oh, wow.
And yeah, I mean, that's not uncommon for people without diabetes. And I think we're only now appreciating it because you can wear CGM and you can see that, which you normally wouldn't have seen.
Right.
Now, mine automatically comes back down and I don't have to do anything about it, but it's not uncommon for it to go above 200.
Can I ask how old you are?
I'm 56.
56. Okay. I'm 52. I have to, wearing a CGM, I have to eat intentionally to get my blood sugar to go over like 160. But I'm talking about like pizza on top of fast acting sugar. As like I had to like gorge myself to make it happen. So it's interesting. Give me, I'm showing off, Steve.
It varies from person to person.
It
for
varies
sure.
from person to person.
And I think breakfast is the meal. If I eat a high carb breakfast, I'm definitely going high.
Okay.
Because it's, it changed the way I ate. I would in the morning would have, some waffles and some peanut butter and maple syrup. And when I saw what that did to my blood glucose, all of a sudden I started eating more eggs.
Everyone who's ever come on here, as Kevin Sayer was on here one time, he's like, I wore my own product and there's like 4 things I just stopped eating.
Yep.
So listen, we talk about even a person without diabetes is going to see an excursion up, but there's also truth, is there not, that a person without diabetes also might see a blood sugar into the 60s throughout the day. So, I mean, it begs the question, like, why were you guys not a little more aggressive with it?
Well, I think the idea is to try and tune the system so that we're improving, we're lowering the average glucose, we're lowering the A1C without increasing hypoglycemia. That was effectively the way it was tuned over those pre-pivotal studies that we did.
Mm-hmm.
And that's what we found in our pivotal study. We lowered A1C, didn't change the amount of time less than 70 and less than 54. Sort of a pragmatic choice to tune it that way. And of course, that means that, in some people are going to have more hypoglycemia and some people are going to have less.
Right. And
we're just trying to kind of pick a middle path where we get the best glucose control we can without putting people at risk.
Yeah. In fairness to every company and every algorithm, there's the nebulous part of the conversation that we don't talk about, which is some people just eat differently. And so you're trying to make a thing that you can just hand to the world without knowing each person individually. So there has to be buffer, I guess, on either side of it. I guess my bigger question is, if the brain trust that is Beta Bionics now existed on day one, do you think the algorithm would be more aggressive today? Like, have you learned more now, or you're still very comfortable with how it's done?
I don't think it would be different.
Okay.
I think we might, we're seeing that we would like to add an exercise button on the iLet,
mm-hmm.
and that wasn't built into it from the very beginning. And so now we want to add it. And I think one of the reasons it wasn't built into it from the beginning is because the iLet kind of started as a bihormonal system, and we didn't really need it for the bihormonal system. And then we got to insulin only, and we found that we were still getting very good, sort of surprisingly good results with the insulin only system.
Yeah.
And it was quite differentiated. It was getting results similar to what other AID systems were getting, but with a lot less work. And we thought, that is a differentiated thing that we should get out there, even though it's going to take us a little bit longer to get the bihormonal product out because of the complexity of doing a drug trial as well.
Right.
So that's why we chose to move forward with the insulin-only system, because it is a big difference. I think it does bring a tremendous amount of value.
Mm-hmm.
But that's also why we're not stopping on the bihormonal system, because we think there's additional value that we can bring by bringing in that bihormonal piece.
Well, back in the day, the glucagon wouldn't hold up in the pump, right? That was the biggest.
That's absolutely right. So we did all of our pre-pivotal studies, or most of our pre-pivotal studies, using the red kit from Lilly, and we would just reconstitute that glucagon, and we had to change it out every day because it wouldn't last longer than that. And shout out to Lilly for providing us enormous amounts of that red kit glucagon for free. They were fantastic about that. We would literally get boxes that were 3 feet on a side full of nothing but those red kits to be able to do our pre-pivotal studies. But that wasn't going to be practical in the long run.
Yeah.
And so that's why we needed a stable glucagon. And fortunately, 2 came along, and we're moving forward with one of those, a new formulation of the Xeris. The actual Xerisol glucagon that's available right now for rescue treatment, that one won't work in a pump because it actually damages the plastic.
Wow.
But a different version of it, a slightly modified version, looks like it's going to work just fine in a pump. And so that's what we're going to be moving forward with. Paul
was explaining that to me in that recording, because I said, you're just going to put Gvoke into the pump. He's like, no, we have to do a formulation change. And I was like, that's really interesting. And pretty cool, honestly, Stephen, that an idea that is how old now? I mean, when did that study happen with those red kits? for you guys?
Well, the very first one happened in 2008.
Okay. So a lot of years later, like 17, it sounds like to me, you're still on it, which is pretty great. I also want to say this too. I recently just floated out into the world. Like if anybody wants to come, I think I said online, if you have a device or a product that helps people with diabetes and you want to come on the podcast and talk about it, come on. And you and I are having a pretty honest conversation, I'd say, about iLet. And I appreciate that because not everybody stepped forward and was interested. So thank you. I really do appreciate talking about it like this, because it's fair to say all these algorithms and they could all be better, obviously, right? It's not a denigration of what they are now. And if we don't talk about it like this, then where's the onus to do the work? You know what I mean? Like all these companies should be in a room right now looking at their data thinking, how can I make this better? And if they're not, I hope they'll consider doing it. And it sounds like that's what you guys are doing. So I appreciate it.
I totally agree. I mean, look, AID is so impactful. It makes a huge difference. CGM was huge and AID is huge. And I think that probably everybody with type 1 should be on an AID system. I think that Beta Bionics with the iLet is trying to be available and reach a group of people that may have a harder time working with some of these other systems that require more sophistication on the part of the user, ability to carb count, choosing the right times to do corrections and so forth.
Yeah.
And so I think that I talk about democratizing good glucose control. It shouldn't be just for the elites. It shouldn't just be for the small percentage of people who are very numerate and, have the best executive function so they can be on it all the time and paying attention and, not working two jobs because, you really with diabetes, it's like a second job. So if you already have two jobs, then, your ability to spend the amount of time it takes to get that excellent glucose control is limited. So I think one of the things that we bring is bringing the possibility of good glucose control to people who might not be able to do it with the other devices. And for people who already are able to achieve good glucose control with other devices, it's another option that can reduce the amount of time they have to spend with it.
Yeah.
Not everybody wants that. I think it's important to note it's not for everybody. The kind of people who want to be on Loop or one of these other systems, or the people who have control IQ, but they've turned it off and they've just got it on, sleep mode at all times because they feel like they can do a better job. Those are probably not the people for the iLet.
Right.
Frankly,
the button pushers and the dial turners might not be your bread and butter, but there's listen, I say it all the time. Well, let me go back. Earlier, when you were describing how the algorithm works, I thought, oh my God, that's how I managed manually, right? Like I think back to like the pro tip series in this podcast, which is just me telling you how I got my daughter's A1C down and stable and how I think about insulin and diabetes. It's all timing and amount and, understanding the variables like that. It's literally what the algorithm's doing. I didn't realize that till the first time I saw my daughter on Loop and I could watch through Night Scout. I watched it work and I thought, oh, I would have temp baseled here or I would have done this. Like, you know what I mean? I was like, this is so interesting. It's doing everything for me and I'm getting to sleep. This is insane. How happy I was about it. But it's never lost on me that even though I watched the podcast help, like seriously, I'm not trying to like blow my own horn here, but this podcast charts in 48 countries around the world, right? Like I wake up to a dozen notes every day from people who are like, oh my God, look at my A1C. It's amazing how many people it touches. And yet, if I stop myself in a quiet moment, I remind myself I'm probably not touching 5% of people with type 1 diabetes. Like I'm not reaching nearly everyone. This is for the people who have the time to listen to it, that have the acuity to understand it, that have the patience to put it into practice, that have the patience to watch it go over and over again until it finally makes sense to them. And then they can kind of do it blindly without even thinking about it. That is not something that's going to work out for everybody. I just know it isn't. And everyone should be thinking about that. Like, because if not, then what we're doing is we have a bunch of different pump companies who are saying to themselves, there's a block of people with type 1 diabetes. This percentage of them can figure out how to use this pump. We'll market to them. And then the rest of them they get left behind. That to me is like, I have thought from day one about this algorithm, like this is for the people who got left behind. And if you can turn it into something that's for everybody, not just for them, then in my opinion, you just jumped ahead. So, everyone else should try to keep up, but, I would love to see this on more people and see how it works out. Speaking of it being on more people and seeing things, have you seen it on somebody who's using a GLP yet? I would imagine that's like a low carb vibe, right?
Right. We have. I don't have statistics for you.
Sure.
And I would say also we do post-market surveillance all the time.
Mm-hmm.
We can look at the whole population of people on the iLet and look at what average glucose they're getting and how much hypoglycemia, all that stuff we look at. Unfortunately, we often don't get any information about other medications that they're on. That's not part of the information that we get. But I am aware of people on GLP-1 agonists with the iLet. And as far as the iLet's concerned, that just means that the person is using less insulin,
right, and
their glucose excursions are less acute, less sharp.
They're eased.
Yeah. And they're easier to manage.
Yeah.
So, and the iLet, of course, is continually adapting to the need for insulin. So if somebody starts on a GLP-1 and their insulin needs go down, the iLet just adapts to that online. And if they are absorbing food a little bit slower, the meal dose adapts to that.
Yeah.
So I don't think there's any reason why you think that it wouldn't play nicely with a GLP-1 agonist. And in the cases I'm aware of, it seems to play just fine with GLP-1 agonists.
I'll say here that my daughter is using Mounjaro at the moment. I've said it over and over again, but so that I estimate she'll use 16,000 fewer units of insulin this year because of it. And and we were doing fine before. We were, in fairness, we're very good at using insulin. So it doesn't matter how high or low carb she is, we know how to manage. But this is just her stability is even more stable. It gives the algorithm, it makes the algorithm look like it's better at what it's doing. You know what I mean? I used to say to people, if you came to my house and said I have to give one of these things back, I'd probably fight for the CGM over the pump. But then once they got integrated, now I kind of see them as one and the same thing. But I'd have a long, hard think before you ask me, what can I have back, the algorithm or the GLP? I'm doing a small series right now with a guy you might know, Tom Blevins. He's an endo in Austin. And Tom and I are recording a small series about GLPs. I am literally hoping to be one of the voices that pushes JDRF and other big institutions into pushing for coverage and testing, for people with type 1 diabetes, just based on what I've seen and what I'm hearing from other people, which has nothing to do with our conversation. But anyway.
Sure. I'll say that, this is entirely separate from my role at Beta Bionics, but I'm still a practicing endocrinologist. And I personally use GLP-1 agonists in people with type 1 diabetes who also have the physiology of type 2 diabetes. And there's plenty of those people, right? There's nothing about having an autoimmune attack on your pancreas or your beta cells that modifies those genetic risk factors for type 2 diabetes. So as far as I'm concerned, you can have both types of physiology. And for those people, absolutely GLP-1 agonists make sense. I think perhaps more controversial is the idea of using them in people with type 1 diabetes who are lean, not insulin resistant. And I think that's where, the companies just chose not to pursue an indication for it. But clearly it does reduce the amount of insulin use, and it does tend to
appetite too.
Appetite, and it smooths out the glucose excursions. So it does make a lot of sense that it just makes diabetes easier to manage.
I have to thank you because you just put that. I've been trying to make that point. I keep fumbling with it every time I try to make it. The idea, you used to hear people say, my doctor says I have type 1 and type 2 diabetes. And then people would say that and you'd be like, you can't have both. And it would kind of people get upset. But my daughter, for example, very clearly has PCOS symptoms, which is just a thing you really can't even get diagnosed, weight gain, acne, high need for insulin, no matter what she's eating or not. And she didn't, she hadn't gained a ton of weight, but she's also 20 still. Whereas I know a person who doesn't have type 1 diabetes is a young girl in her mid-20s who has PCOS and is a clean eater who exercises daily, who gains weight every week, just can't stop, right? And goes on Wegovy, and boom, it all just ends. And the weight starts coming off and everything goes back to normal. It's absolutely amazing. But what you're starting to see right now, and you probably know this because it sounds like you're doing it, is you're having to diagnose your patients as having insulin resistance and type 1 diabetes to get around the quagmire that is insurance at the moment on this. But Dr. Blevins believes that if you don't go out there and do the studies, that it's going to be very difficult to push through insurance, and that it's going to take a big voice to push the studies along. So I'm trying to magnify that if I can, just like I'm trying to do with you and anybody else. Listen, there's part of me, Stephen, I don't want everybody fighting, and I take ads from a pump company. Like, I have no trouble saying that, but I don't want anybody getting comfortable. Like, I make a podcast and, people pay me for ads, but I got a kid with diabetes. I need you guys all out there hustling. You know what I mean? For anybody who might be listening, thinking, God, I can't believe Scott had these people on when, Omnipod buys ads from him. I want Omnipod to work hard. And I want you all to work hard. You know what I mean? So,
absolutely. I think it's incumbent on all of us to continue innovating. And I'm thankful that we have multiple different AID systems, because I think they're not all perfect for everybody. And I think everyone should be on an AID system, and it should be one that fits their lifestyle and their predilections and their interests, and it works for them. And so I think there's no way that any one system is going to be all things to all people. So I think it's great that there are choices.
I agree. I absolutely think that when you're being diagnosed, the next thing you thought you should have is, what's that you're putting on my arm? Is that a CGM? What is that? But you shouldn't leave the hospital without a CGM. If you had a heart issue, they would put a monitor on you. They would not let you out of the hospital without it. But
I 100% agree.
Yeah.
And one of the things I do is I still work in the hospital on the weekends. We have this inpatient diabetes service, and it's getting pretty big now. It takes 3 doctors to cover it every weekend. We see all these patients in the hospital, and we're seeing the patients who are already on our service with consults to us, but we also get new onset people, and people get new onset type 1 diabetes all the time as adults. So I see these folks, and I really try and take it upon myself to try and get them on a CGM as soon as possible. Send the script down to our pharmacy and get them on a Dexcom or an Abbott sensor before they leave the hospital, and put in a statement of medical necessity for an AID system if they're willing to consider it.
Yep.
As soon as possible. I'm really grateful that there are more than one systems out there that are automating glucose control. I really like to get people on CGM as soon as possible after they're diagnosed.
Mm-hmm.
And there's adults getting diagnosed all the time, and I really want everybody to think about an AID system on the day they're diagnosed, when I see them in the hospital.
Yeah, no, I completely agree. And I like, again, not only is it good for people to have choice, but from a different perspective, it is very good if the space is not controlled by one company. We've seen it in the past. That company gets comfortable and then nobody gets served. So
that's absolutely true. Yeah. And I think it's really important for us to continue innovating. Once you have something that's approved in a very highly regulated industry like this, there is the tendency to feel like, well, it would be too costly, too time consuming to continue to innovate. Let's just keep pushing the product that we already have. But I don't think any of us should be satisfied with that. No. We should always be looking to how we can make it better.
Yeah. Listen, I have a 2-year outboard for podcast. They should be doing the same thing. As soon as everybody, I always say, you get your thing through the FDA, everybody gets a vacation, then we come back and we start thinking about how do we push this farther. And if you're not doing that, then I think shame on you a little bit. So seriously, like, it's just, you saw it in the past. One company had control of everything and they were just like, woo. And now look at them rushing around trying to get back in the game. You know what I mean? So
it can be that kind of behavior winds up coming back to burn you in the end, but it tends to be years later in their case. I think now that there's more people in the game, it doesn't take as long
Right.
for that kind of behavior to loop back and burn you.
It's not just cyclical now because it's cyclically happening like 4 or 5 different buildings. And that really is valuable for us because, listen, if you're going to talk about the business of it, we got the big thing through. Now we're going to make the money. I'll cut costs right now. I'll be a big hero, bring in a nice bonus for myself. I'll retire. And then the problem will be on somebody else when we're not innovating anymore. That's the backside business problem. So I guess what I'm saying is if you're in a business where that's happening, you better speak up or 10 years from now, your job ain't going to be worth much. Anyway, there. I just want to make sure everybody's working, Stephen. That's all. I got a daughter I got to worry about. You know what I mean?
Well, we are working very hard on it. And as you know, we launched the product with G6, and shortly after we put out an update that made us compatible with G7. And we've been very clear that we want to be compatible with any CGM that is able to meet the iCGM standards because we think people should have choices. Mm-hmm. And we're going to continue to innovate in other ways as well.
Cool. It sounds like maybe you've reached out to the people at Eversense then, perhaps. They just got their IAPS distinction, didn't they?
They did.
Yeah, or no, I used the wrong terminology, the iCGM, excuse me. But
iCGM.
Yeah.
Yeah, and I'm actually a fan of that technology. One of the things I do in clinic is to replace those Eversense sensors. And I think it's a good system.
That's excellent. Good. Well, hopefully, I mean, they buy ads for me too, like just so I'm being clear. But I always say to them, like, like how the transmitter vibrates. I was like, wouldn't it be cool if the pill vibrated? And they're like, wouldn't it be? And I was like, it would be, wouldn't it be? And it's like, somebody work on that. That's a great, I mean, can you imagine if you had an implantable CGM that gave you a little shake if you were low or 2 little shakes if you were getting high? That's insane. I think that'd be fantastic. Anyway, is there anything I didn't ask you that I should have, something we left out?
Let me think. I know there was some, we had some things on our.
Because I have here, can you tell me about?
You know what? There was one that was on there. What are the best practices in the first 2 weeks? I'd love to address that.
Please do it.
All right. Well, one of the questions that comes up is what to do when you first start on the iLet. What are the best practices to get the most out of it? And those best practices really are derived from the way the algorithm works. What you want to do is give the algorithm the best chance to learn you as quickly as possible. And because the way the meal algorithm works is it looks at the 4 hours after the meal, we do ask people to space out their meals by 4 hours initially to allow the iLet the chance to learn how much insulin they need for the meal. Because we have these rules that if you get another meal announced within that 4 hours, it will cancel the adaptation.
Okay.
Now, there is an exception to that, which is if you announce multiple meals in the first hour, it will actually combine those meals and adapt on the sum of those meals. And that's quite useful for announcing meals by courses. Say you go out to eat for dinner and you have an appetizer, and that appetizer has, since you're out to eat, maybe as many carbs as your usual meal. Mm-hmm. So you announce the appetizer and now your main course comes out and that may have more carbs than your usual meal. So you announce that and maybe you then have dessert. You want to announce that. It will combine all those announcements and adapt on the sum of them. And that may be better than trying to anticipate at the very beginning of the meal how much total carbs you're going to have for the entire period for 2 reasons. One, because it may be hard to do. You're not sure whether you're going to have that dessert or not at that point. But 2, because if you took all of the insulin, if you told the iLet you were going to have all those carbs right at the beginning, it might give too much insulin too early. Mm-hmm. In other words, an hour later, when you actually have the dessert, you want to have that insulin then, not at the very beginning. It might be too much too soon. But after that first hour period, if you announce another meal in that 2 to 4 hour period, it'll cancel that adaptation. Okay. So if you never space out the meals by 4 hours, it's never going to have a chance to learn. Mm-hmm. After that initial learning, then you can be much less regimented about it. If you decide to have a snack a couple hours after the meal, have at it. Go ahead and announce it. That'll cancel the adaptation for that meal, but so what? There you have lots of opportunities to sort of update the meal announcements. And most people tend to eat about the same amount, same stuff anyway, right? Yeah. So you probably don't need to update it. But in that first week or so, spacing them out is good. Also, eating meals that really are typical for you or usual for you is good, so that it has a chance to learn that. There is always this temptation, you get a new system, like a new fancy car, you're like, let's try this thing out.
See how fast this goes.
See how fast it goes. And we definitely see some of that. I remember in one of our first outpatient study, a long time ago now, this was early on when Twitter was new and shiny. And one of our users had a Twitter account, and he was tweeting all of his meals that he was having. And, one of them was a plate with a burger, fries, a couple beers, and then a stack of little dessert dishes.
Mm-hmm.
And he's like, I just had this meal and, 7 bowls of ice cream, #bionic pancreas.
Can I tell you how old I am? I know that photo.
Oh, do you?
Yeah. I can't believe I just thought, have I been doing this that long? I know exactly what you're talking about. That's crazy.
Yeah.
So what's the downside of him doing that?
Well, the downside, of course, is that the chances of being able to adapt on that meal are not very good. And certainly it's not a usual meal, at least not for most mortals.
Yeah.
So really, if you want the iLet to learn you've got to give it the right information. And this is when we see problems, these are the kind of problems we see. Mm-hmm. Somebody, like, let's say they have habits that they've developed over the course of a long time with diabetes that totally make sense with some other systems, but don't make sense with the iLet, but they find it hard to readjust. So I'll give you an example. Somebody has that first meal with the iLet and their blood glucose goes high. And that's a common occurrence because it's starting off with this very low dose. They see that go high and they think, oh, this thing isn't going to give me enough insulin. And so the next time they announce a meal, they announce it as a more meal instead of a usual meal, even though they're eating a usual meal.
Right.
If they just announced it as a usual meal, it would have given them more insulin because it learned from the last time.
Okay.
But now it doesn't have a chance to show them that. And they will get a little bit more insulin that one time because, of course, they announced it as a more than usual. But that will actually make it think that they need less insulin for a usual meal. Mm-hmm. So it has the exact opposite effect over time that they intend. So it works once to get more insulin, but in the long run, they'll actually get less.
Yeah.
So the iLet, because it's adaptive, it has this unique characteristic that you can't trick it, but you can confuse it. Mm-hmm. And if you tell it things that aren't true, it will learn the wrong thing.
Right.
And another example that is totally understandable, given how people have been managing their diabetes, is they're about to eat a usual meal, but they're like, but my blood glucose is dropping. So I'm going to announce it as a less meal instead of a usual meal, so I'll get less insulin. The problem with that is that the iLet is already taking into account that dropping glucose in terms of its basal dosing, its correction. It's like if you're in a self-driving car and it's turning around a corner, but you grab the wheel and turn it too, and now you hit the curb. You're both trying to take care of the same thing, and you're overdoing it.
I've come to believe that we've reached a level in some technology you can't outsmart it. You can't even understand what it's thinking about. And, your little thoughts are going to get in the way. I learned that with Loop when my daughter started using Loop. Like, if this isn't working, our settings are wrong, our timing is wrong. Me trying to fix a problem is just going to make it more confused. And it wasn't a learning situation. Yeah. I'm going to try to hack through it. Plus, why am I putting myself in that situation where I'm constantly having to do more when it should be automated as much as it possibly can be? It's AI, right? Like it's a learning model. It's considering just more things than exists, let alone that you could consider. And it's on different timelines, which is
that's right.
Yeah.
All that adaptation is going on. And if you try to outsmart it, to hack it, it'll just screw up the adaptation. Things will get worse, not better. Mm-hmm. But that is a really hard thing, especially for the knob turners, button pushers folks. It's just so hard to sit on their hands and wait for the system to learn. And so we, some of those people do want to try the iLet, and we're encouraging of that if they want to, as long as they're, willing to at least try reconsidering how they manage things. And some of them find that they can push through. They can sit on their hands for long enough for it to learn and do well. And then they think, oh, great, I'm fine with not doing all that extra work as long as the results are good.
Yeah.
Interestingly, we've also seen some folks who got undeniably great results on the iLet. In some cases, better than the results that they were getting with all of their work. And they just still find it an uncomfortable thing. They want to be able to go in and give that insulin. Even if they're not going to achieve a better result, that's just who they see themselves as being.
Yeah.
And that's fine. That's fine.
It's interesting. It is. It's the psychological. I've had these existential conversations with type 1s before about like, what would you do, if diabetes disappeared? And the number of people who say that they wouldn't even want that to happen because they don't know who they are without diabetes is fascinating. Like, you know what I mean? Like it really is interesting how much it becomes a part of who you are and what you do every day. Oh, anyway.
Yeah, and there's just sort of a pride of being able to manage it. Like, I'm really good at this. This is something that I have got down. And so taking it away feels like a loss almost.
Yeah, I did all this work to understand this thing. I let it go. I have to tell you, even between you and I don't want to sound pompous, but I can manage insulin within an inch of its life. I'm really good at it. I kept my daughter's A1C like 5.3, 5.5, no problem through like middle school, high school, no big deal. And then I was like, oh God, she's going to go to college. And, like she's not going to do the stuff I do. But luckily, prior to that, we started to use a loop before Omnipod 5 was even available. And I got to sleep. And once I got to sleep, I thought, oh, I was going to die. I didn't even know it. like I was my no kidding, that by the time I got my daughter off to college, like I had to go to a doctor and say, okay, now we got to save me. Like, you know what I mean? Like my health had gotten poor. Just it's not sustainable. It just really isn't. So
that's right. Yeah. I mean, that's very impressive. And I'm always impressed by people who can do that. And there are plenty of people out there who can do it, but there is a cost to it. Yeah. There is a real cost to it. It just takes years off your life, I
was not going to make it the whole way. Like if I had to do that for another 10 years, I've had times in my life where I've sat in bed in the middle of the night and my brain is vibrating because I hadn't slept. And I've actually had the conscious thought, I'm going to have a heart attack. Like I'm going to die. Like I have to go to sleep. And then you look at that blood sugar and you go, I can't right now because we made a correction and like blah, blah, blah. Like that whole thing, all that is gone. Like and I'm telling you, if you add glucagon to that, I might sleep with a noise machine. Like, I might be like, I really don't want to hear a damn thing. Just let me sleep. Anyway, good luck to you. Godspeed. Seriously, I hope it goes exactly the way you guys are envisioning.
All right. Thanks. Yeah. A real pleasure talking to you.
Oh, sincerely.
Thank you for taking the time to have me on.
No, it's a pleasure. Hold on 1 second for me. A huge thank you to one of today's sponsors, Gvoke Glucagon. Find out more about Gvoke HypoPen at gvokeglucagon.com/juicebox. You spell that GVOKEGLUCAGON.com/juicebox. A huge thanks to US Med for sponsoring this episode of the Juicebox Podcast. Don't forget, usmed.com/juicebox. This is where we get our diabetes supplies from. You can as well. Use the link or call 888-721-1514. Use the link or call the number, get your free benefits check so that you can start getting your diabetes supplies the way we do from US Med. Jalen is an incredible example of what so many experience living with diabetes. You show up for yourself and others every day, never letting diabetes define you. And that is what the Medtronic Champion community is all about. Each of us is strong, and together we're even stronger. To hear more stories from the Medtronic Champion community or to share your own story, visit medtronicdiabetes.com/juicebox and look out online for the hashtag Medtronic Champion. If you're not already subscribed or following in your favorite audio app, please take the time now to do that. It really helps the show. And get those automatic downloads set up so you never miss an episode. Thank you so much for listening. I'll be back very soon with another episode of the Juicebox Podcast. The episode you just heard was professionally edited by Wrong Way Recording. WrongWayRecording.com.